here at Baycrest outreach team. So you can hear that this webinar today is being recorded. I wanted to let everyone know that when we get to the Q&A section, we're going to stop the recording aspect of things just due to the sensitivity of the topic and just to give everyone the opportunity to speak freely. So welcome again to our behavioral support rounds. Today we have Andria Bianchi, who will be talking about ethical considerations related to sexual expression in older adults. Before we begin, I just wanted to talk a little bit about the land of acknowledgement. So although we are meeting virtually, we acknowledge that Baycrest and our related Toronto Central Region behavior support programs operates on the traditional territories of many Indigenous nations, which have cared for the land thousands of years, including the Anishinaabe, Haudenosaunee, and Huron-Wendat people. And we recognize the current treaty holders, the Mississaugas of the Credit First Nation. This land remains home to many diverse First Nations, Inuit, and Métis people, and is subject to the dish with one spoon wampum, an agreement to peaceably share and care for the Great Lakes region. We are grateful to have the opportunity to work on this land today. You may live and work in different territories, so we encourage you to reflect on the land on which you are located and to consider your relationships to the land and to the people who are the traditional keepers of the land. So some housekeeping, as mentioned, we are recording this webinar, but the recording will stop at the end for the Q&A component. Your microphone is muted, and there'll be Q&A at the end of today's session. So again, the session will be about 40 minutes, and then we'll have about 15 minutes of discussion and wrap up. Please place any of your questions that you may have in the Q&A, and if you have questions related to tech support, please message Agnes. So you'll see Agnes, it says telehealth. For those of you interested in receiving a certificate of attendance, please enter your name and email address in the completed evaluation form that will pop up at the end. So again, I wanted to welcome Andria Bianchi, who's our Baycrest clinical ethicist. She'll tell you a little bit more in terms of her position there. She is a clinical ethicist at the Center of Clinical Ethics, Unity Health Toronto, where she primarily offers ethics support to Baycrest Hospital and LTC, Toronto Grace Health Centre and Surrey Place. Andria focuses her ethics practice on ethical issues related to rehabilitation of older adults and persons with cognitive impairment. Her doctoral work focused on the ethics of sexual consent in older adults with dementia. In addition to her career in clinical ethics, Andria is an assistant professor, status only, at the Dalla Lana School of Public Health, University of Toronto, and an affiliate scientist at Kite Research Institute. Andria also serves as chair of the Stakeholder Advisory Council of the Retirement Homes Regulatory Authority and is on the board of directors of the Canadian Association of Practicing Healthcare Ethicists. So welcome, Andria. I'm going to stop sharing and allow you now to share your screen.
Yeah, sounds good. Thank you so much. Thanks everyone for being here. And thank you, Kara and the BSO, for welcoming me. So I will attempt to share my screen. Hopefully all goes well on that front. All right. Oh. Okay, are you able to just see my slide?
Yes.
We are. Okay, so you see the full slide, perfect. Okay, so yeah, thanks very much again for welcoming me here today to explore this topic that I certainly find interesting. Hopefully you do as well, and certainly ethically complex. So it's titled Ethical Considerations Related to Sexual Expression, broadly speaking, and older adults. As Kara kindly mentioned, my doctoral work in relation to the topic of sexual expression was really around actually sexual consent and sexual expression and some of the ethics around that. I'm not so much going to talk about sexual consent in and of itself today. I'm going to talk more about some of the ethical dilemmas that arise when certain cases come to light and there are these complexities related to sexual expression, older adults with cognitive impairment living in care facilities for the most part. All right, so just in terms of disclosures, so certainly I'm an employee of Unity Health Toronto. I'm serving primarily Baycrest and typically located there, which is wonderful. Also supporting Toronto Grace and Surrey Place, and sit on a couple of different boards or advisory committees. I have matters of ethical interest and views on these matters, and my views are not necessarily those of my employer nor the organizations within which I work or I volunteer. And I'm an ethicist. I'm not a lawyer, so these presentations certainly shouldn't be construed as legal advice. So in terms of learning objectives for today, so I'm hopeful that by the end, everyone here will feel comfortable and be able to identify ethical dilemmas regarding older adults and sexual expression that come up at your workplaces or elsewhere. Appreciate individual values and beliefs that may contribute to these ethical dilemmas coming to light, and implement strategies to actually help manage these relevant ethical dilemmas when they do come up. So in order to achieve these objectives, I'm going to discuss ethics and ethical dilemmas in general, just to ensure that each of us have the same foundation and so that you understand where I'm coming from, the lens through which I am being approached with some challenging cases related to sexual expression in older adults, and the lens through which I approach those circumstances. We'll reflect upon 3 different case studies and consider why they may result in an ethical dilemma, since each of us would have had that definition of an ethical dilemma as indicated in number 1. We'll explore the significance of this topic in light of the current context. So we'll talk a little bit about the current context, and then we'll consider some approaches to respond to the complexities. And as Kara mentioned, I'll speak for about 40 minutes or so, and then very open to hearing your thoughts, questions, perspectives, circumstances that, of course, with non-identifiers. So we can all continue to learn and grapple together. So in terms of what clinical ethics is, and I recognize that it's not a profession that necessarily everyone is aware of. So clinical ethics, or sometimes referred to as bioethics, is this systematic and critical reflection on ethical issues that arise in healthcare. So clinical ethics, so what I do is I collaborate with and I support staff, clients, patients, families who are in really complex circumstances where there is not a clear right answer, oftentimes in terms of what they should do. So I'll support decision-making processes, help people decide what they should do, why they may want to pursue one particular action over another, describe how they may want to go about a particular action. Clinical ethicists are not decision makers. Rather, we support decision-making processes, help facilitate fair decision-making processes, and offer insights regarding the actual decision that is made. So many, though not all of us, of course, here today are going to be from regulated health professions. But I would say that irrespective of our professional backgrounds, I imagine that many, if not all of us, have heard of certain values, certain principles that are important for healthcare providers, broadly speaking, for anyone working with clients, patients, to take into consideration when they're thinking about the way that they practice, the manner through which they provide care. So some of these might be familiar to you. So when we are working in a care home or a care environment, oftentimes you'll hear about autonomy, this principle, this idea that we should respect people's decisions that are reflective of themselves, that we should give people the opportunity to make their own decisions about themselves. Beneficence, this idea that we should be promoting benefit, that we should be helping people. Non-maleficence is this idea that we should be preventing people from experiencing harm, and it might be various types of harm that we are trying to and feel a duty to prevent people from experiencing. Justice. Oftentimes, this concept of justice, it comes through this concept of equity, this idea that we should be providing equitable access to care and equitable care in general. Trust, transparency, dignity, honesty. So there are, and this is a non-exhaustive list, of course, but there are a whole bundle of ethical principles and values that are relevant to the work that each of us presumably does. The challenge and the reason as to why clinical ethics is, I think, an important discipline is because ethical dilemmas inevitably arise in the work that we do. And ethical dilemmas are circumstances that exist when these principles or these values, they guide us in different directions. And because they're guiding us in different directions, decision makers are unsure of what to do. So a perfect example of this is if a person that you're working with makes an autonomous decision that is going to inevitably result in some harm. You as a care provider might respond to that and think, well, do I prevent them from harm, thereby preventing them from fulfilling that autonomous decision? Or do I honor their autonomy? Do I respect their autonomous decision, knowing that it's going to result in harm that I could prevent? So even though each of these ethical principles and values are so important, it's often the case that they're going to conflict with each other, and that creates an ethical dilemma. Another way of thinking about an ethical dilemma is to think about circumstances that you might encounter where they're complex circumstances, and there's many ways that you can, legally speaking, respond, but you're unsure of what you should do, ethically speaking. So it's this could versus should. And a very simple description of an ethical dilemma is when ethical principles or values, they guide us in different directions, and decision makers are, as a consequence, unsure of what they should do or unsure of what to do in response. It may be important to note, perhaps particularly given the topic that we're going to delve into in a moment, that an individual person, just one individual, may experience an ethical dilemma due to their own feeling of being pulled in multiple directions. Right? You as an individual practitioner, an individual person might feel, oh, I want to respect this person's autonomous choice, but I also want to prevent them from harm. So you might feel pulled in multiple directions and experience an ethical dilemma. Alternatively, a group of staff might experience an ethical dilemma together when they're trying to develop, let's say, a care plan for a patient or a resident. When developing a care plan, if each member of the team feels differently in terms of what they should do, in terms of what principle or value should be prioritized, then that group may actually experience an ethical dilemma. And the cases that we'll get to in a moment are examples of cases, some of them that I've been consulted on, and it has almost always been the case that this has come from teams that really aren't sure what to do, and there are conflicts that arise. So just to give you a sense, and this is really just a background in terms of ethics and ethical dilemmas, broadly speaking, there's a whole number of ethical dilemmas that you have presumably, possibly encountered or heard about. So if we think about how to manage wait lists and who to prioritize, is it who's going to benefit the most, or is it who wants it the most, wants the care the most? Consent, capacity, substitute decision-making. If we think about a person whose capacity to consent to personal care decisions fluctuates, at what point do we consider them to be making decisions that we ought to honor, even if they're incapable at the time? If we think about confidentiality, disclosure, truth-telling, under what circumstances should we tell the truth? Should we disclose certain information? How should we disclose information? Covert medication administration. When is it ethically permissible or ethically defensible to covertly administer a medication that could cause quite a bit of benefit, even if a person doesn't want it? The use of restraints, certainly when it comes to restraint policy and use, and thinking about the complexities that can arise in those circumstances, there's often ethical tension and dilemmas. And then, of course, the one that we're really going to talk about today is sexual expression. And so I'm narrowing things a little bit, sexual expression and older adults with cognitive impairment who are living in residential care environments. And these are the types of circumstances that I'm particularly interested in. And the reason as to why I suggest that this topic in and of itself can cause or result in an ethical dilemma is going to hopefully become evident in a moment. So we're going to explore that after reviewing a couple of case studies. All right. So what I'm going to do right now, I'm going to present 3 different case studies involving sexual expression and older adults. And while going through the cases, I want you to take note of your intuitive response or your immediate reaction, so to speak. And what I typically do when presenting these kinds of cases, and what probably won't be very hard for this particular group, is I want you to imagine that you are someone involved in this person's circle of care. And you need to decide how to respond to the case that's being placed in front of you. The cases as outlined are rather bare bones, but I am hopeful that everyone here will be able to imagine that each kind of general circumstance may arise in the space that they work within. All right, and so the first case that I'm going to present, and this is, I've certainly received consults that align with this case, but it is one that I am pulling from the literature from a theorist named Peter Bartlett, and it's from an article a number of years ago, but it is one that resonates with me given the consults I've received. So we're going to imagine that there's an 84-year-old female, we'll call her Ms. X, and she has a moderate dementia living in a care home. Her husband of many years comes in on Saturday afternoons, and he closes the door to her room whenever he arrives. The care staff are confident that sexual acts are taking place, and we can imagine that in an environment where people are walking around frequently, where there actually isn't that much privacy, even closing a door, hearing certain sounds, care staff are cognizant of what the individuals look like, their appearance, their dress. So the care staff are quite confident that these sexual acts are taking place. But because of her dementia, there's reason to believe that Ms. X would be unable to fully understand the nature of her husband's sexual behavior. So I'm going to move on to a second case, but I want you to take note of your intuitive response to this. What is it? How do you think the care home ought to respond? You ought to respond, your colleagues. What is that immediate reaction that you have? Or if you've encountered this kind of case, perhaps you've grappled with it a little bit. Where did you land? Okay, so in the second case, we're going to imagine that there is a 92-year-old male with a mild dementia. He recently and he voluntarily agreed to be placed in a residential care environment because he couldn't care for himself anymore in the community due to physical disability. He frequently attempts to touch and to caress male staff when they're caring for him. And he is seen holding hands with another male resident who has a more advanced dementia. The other male resident, the person that the 92-year-old new resident is holding hands with, this other resident was married to a female for many years, though she recently died. And same as the first case, I want you to just take a moment to check in with yourself and think about how you might respond to this. What's going through your head right now? How are you thinking, feeling about this case? And again, these are cases that I've certainly seen time and time again. Perhaps you have as well, or perhaps they're new. All right. And then the third case that I'm going to present is that of a 75-year-old female, Ms. B. She has Alzheimer's dementia. She was just diagnosed last year, but there was a rapid cognitive decline. She's frequently agitated. And of course, I didn't spell out exactly what this agitation looks like, but we can imagine a number of things that the ways that she might be expressing this agitation, but she is frequently agitated. She's unable to communicate effectively. So has some impairment in regard to her verbal communication skills. Her husband of 50 years, he has his own health challenges and he's unable to meet her care needs in the community. And this is what ultimately prompted her admission to care home. Her husband does visit as often as possible, though it's somewhat limited. And we can imagine that's because of his own health challenges, his own commitments, his own things going on. But he does come as often as he can. And we can imagine, just to further complicate the scenario, perhaps that he is, a loving husband of 50 years, that they've had a very positive, healthy, committed relationship. Ms. B and another male resident, they are seen wandering into each other's rooms frequently, holding hands. Ms. B seems happier. She seems less agitated when she is around this resident, and the staff do take note of that. One day, Ms. B and this other male resident, they're found lying in bed together and they have some clothes removed. So similar to the last two cases, just what is your intuitive response, your reaction to this as well, the case of Ms. B? Each of the three cases have some similar themes, some similarities, but there are also some really important distinctions, I think, that may influence us to react differently to them. And that's, of course, intentional and calculated. All right. So we've gone through what an ethical dilemma is. We all know that an ethical dilemma are circumstances when we get pulled in different directions because of the relevant values and principles that relate to the case at hand. And we just are unsure of what we should actually do. But the dilemma itself is often caused by these value conflicts that exist amongst ourselves, within ourselves rather, or amongst a group of individuals. And so when we're thinking about each of these cases, the question I pose is, well, why would each case potentially result in an ethical dilemma, right? Where we might be able to recognize that there is some discomfort. Sometimes I like to tell staff that an ethical dilemma, one way of knowing that you might be experiencing one is if there is kind of an ick feeling in your gut, just something doesn't feel right, you're unsure of how to respond. And so the reasons as to why each of these cases may result in an ethical dilemma is because in general, I mean, sex is a value-laden, moralized, relatively taboo topic. It's presumably the case that almost every individual has varying values and beliefs in regard to what is right, what is wrong when it comes to circumstances involving any kind of sexual expression. And we'll talk a little bit in a moment about where these differing values and perspectives may actually come from, certainly. But it's presumably the case that these ideas of what's right and wrong actually is going to differ quite a bit. And so the reason as to why each of these cases may result in an ethical dilemma, well, if you recall the first case of Ms. X, that was the 84-year-old female, moderate dementia. Her husband would come to visit her on Saturday afternoons and close the door. It may be the case, and when I've been consulted in the past on this, it's been the case that some team members may respond and say, you need to inform the husband that you're worried about her inability to consent to sex, and you need to tell him that he actually can't engage in sex with her. If this response feels right to you, and I'm in no way going to say what is right and wrong, because I think as you'll gather, it's really going to depend every circumstance and how to respond is case dependent. But if that response feels right to you, that they shouldn't be engaging in sexual acts, talk to the husband, then that might be based on your prioritization of this principle of non-maleficence, this idea that protecting Ms. X from the potential harms that could result from her engaging in non-consensual sex are significant, and we ought to protect her from harm. On the other hand, it might be the case that you or another staff member would actually say, do nothing. If the husband comes to visit her, let him go in, close the door. We know sexual acts are taking place, but ultimately turn a blind eye. And that is probably not because that staff member or you don't care at all. It may be because you prioritize the value of resident privacy. Another staff may also say, well, do nothing, just leave the door closed, but not because of privacy, but rather because of an impression that Ms. X can make an autonomous decision about how she engages with her husband. So as you can see, an ethical dilemma, it may arise because of differing perspectives around what's right and wrong, and based on the prioritization of particular values or principles that one holds true to a particular circumstance. And so similarly, the second case, and this is the one that involved the new male resident in a care environment holding another male resident's hand, where the second resident was married to a female and his wife recently died. In response to this case, some staff may say, well, separate their hands. I've actually received a couple of consults now about hand holding. And we can certainly talk about this in the Q&A if you're interested, because sometimes these questions will come up in relation to consent, this concept of consent. But just thinking about that scenario, someone might say, well, you should actually separate their hands. And this might be because of the idea that the second resident would not want to hold hands with another male, since he was clearly heterosexual if he was married to a female, right? Of course, I'm saying this, and I think there are reasons to question all of these assumptions, but this could be an assumption that does drive one to say, well, separate their hands. If we want to respect his autonomy, we're going to look, or his past autonomy, if we're going to say he doesn't have it now, his precedent autonomy, separate their hands. Another staff member, though, might say, well, no, let them hold hands because of this idea that it's actually causing some benefit, perhaps. It's not causing harm. And so that staff member, if that's you, you may be prioritizing this principle of beneficence. But as you can see, each of these circumstances, depending on the values or the principles that we prioritize, if they differ from another team member, there's going to be an ethical dilemma that arises. There's going to be a conflict or some tension and uncertainty in terms of, well, what do we actually do next? How do we resolve this ethical dilemma? We're not sure what we should do. We're disagreeing about what should be prioritized. And so how do we move forward? And we're going to get there in a moment, because I do think that there are some strategies that are helpful to resolving ethical dilemmas specific to sexual expression and older adults. When I have posed to people the reason, or that my interest in sexual expression and older adults with a dementia, specifically when I've informed people that this is of interest to me, I have received some pushback in times. Well, why are you actually interested in that topic? There are so many ethical dilemmas that exist in healthcare, right? Why that topic? Why are we talking about sex or sexual expression instead of something else? And why older adults? And so the next couple of slides may or may not be relevant to this particular audience, depending on the lens through which you're approaching this and the spaces in which you work. But we know what ethical dilemmas are. We know why cases involving sexual expression in people with a dementia might result in ethical dilemmas. The reason as to why we're talking about it is, well, there's a few slides on the reason as to why. So, of course, this is not going to be surprising to anyone, I don't think, that we have an increasing aging population, an increasing number of dementia diagnoses. We know that approximately a quarter of Canada's population will be over 65 in, just a few years, really, by 2036. We know that dementia mostly affects that population. We know that there are estimates that in Canada, 1 million people approximately are expected to have a dementia by 2030, and that's just a few years away. And worldwide, we know that there's anticipated to be more than 75 million people. So ultimately, we know that these kinds of dilemmas are going to continue arising in the spaces within which we work. And we know that we're going to have to address them. But most importantly, perhaps, and what I ultimately argue, is that I think we have a responsibility to think really hard about these kinds of cases in a manner that is ethically defensible. And this is because of this current context. Part of the current context involves the stereotypes and the biases that exist within our society as well, that do certainly contribute to the ethical dilemmas and our responses to them. So we know, and some of these citations are actually, there are some updated ones certainly, but some of the articles that this is referencing, and there's a relatively fulsome reference list at the end, are, I think, relevant today and very important. So we know that there are stereotypes of an asexual old age, and that actually remains quite pervasive, that these stereotypes shape not only popular images of older adults, but also our research and our policy agendas. And when I have done and continue to do research related to sexual expression in older adults, there is never enough literature, never enough research being done to really advance things in regard to the field. When you talk about sexuality, and this is a quote that is pulled from Quinn, Happel, and Brown, it's an article from about 12 years ago, though there are some updated articles that have these same themes coming out from care staff. And so this is when you talk about sexuality, a large number of staff tend to be very uncomfortable with the idea. They believe that our patients should be asexual, that they don't have a right to sexuality, that they feel very uncomfortable that these people should have a sexual life. And then this is another quote that is from a care staff as well, and one that was interviewed, which is this idea just that society is generally uncomfortable with the notion that people who are ill or disabled might still want to have sex. So we tend to, because of these stereotypes, actually disregard this topic as one that is important in general and of ethical significance. So I do think that this context is problematic insofar as existing stereotypes of older adults and or people with disabilities actually don't reflect the reality. And the reality is that we know that older adults and that people with a dementia, that they are going to be expressing themselves sexually, that many are going to be expressing themselves sexually. are going to maintain an interest in expressing themselves sexually, irrespective of the environment within which they live. And we also know that sexual expression can be very relevant to a person's identity, to their personhood. And when we talk about things like providing person-centered care, if we are caring for people, for persons who have an interest in expressing themselves sexually, then it seems like recognizing this reality and responding to any of the dilemmas is something we ought to do. It's actually a part of providing person-centered care, though I don't think it's a part of providing person-centered care that we frequently talk about. And so on the next couple of slides, I'll share a couple of bullet points that really just are a couple of studies that have been done to really just drive home this idea that older adults are, of course, interested in expressing themselves sexually, interested in close relationships, intimate relationships. And I have a couple of comments in relation to each of these studies. So one of these studies, it was small, it was 44 people, right? And this is, of course, a wide range of ages between just the age of 50 all the way up to 92. And ultimately, this study concluded that sex is seen as an important component of a close emotional relationship in later life. One of the 76-year-old participants noted that it's the physical problems that actually make your sex life less, really. It's not the actual needs and wanting. And oftentimes when we are seeing people express themselves in sexual ways, those ways are labeled as behaviors. Sometimes it is a need or a wantingness that is being expressed, because those needs and the wanting is still there, but the physical problems, and we'll get to some barriers as well, make it challenging. In another study, and this is a much larger study, of course, a quarter of the couples that were surveyed, ages 75 plus, they had sex at least once per month. So this is penetrative intercourse, though in a lot of these studies, sex or sexual expression was actually just very broadly speaking. So any type of sexual expression, which could also be in relation to one's desire to put on clothes or not, hand holding. So very, very, very broad. And I would argue against some of these being seen as sexual expression themselves. And then another study is from quite some time ago. I put it in here for a reason. So in this study, again, it was like a 30-year-old study. There have not been a lot of studies done on actual residents in relation to this topic. But this study is particularly interesting because there was over 200 people who were interviewed, 100 male, 102 female residents in a California retirement home. 62% of the men and 30% of the women over the age of 80, they engaged in sexual intercourse sometimes. And 83% of the men, 64% of the women engaged in some form of physical intimacy without intercourse. Now, in this article as well, these were individuals who wanted to engage in physical intimacy and sexual intercourse. I find these statistics particularly interesting because you'll note that the male residents there's higher percentages of them engaging in sexual intercourse and physical intimacy. And one potential reason as to why that is the case is because of the way that women are frequently socialized when it comes to discussing sex and this idea that, well, you should be passive or less sexually interested than men. And so actually expressing these things on a survey, some folks have suggested you're not likely to get accurate results, which I actually find quite fascinating. But ultimately, we do know that people who are older are going to continue to want and need sexual expression. So it is incredibly important. I hope that I've already made the point that it is a part of a person. And so when we're thinking about person-centered care, this is something that we need to be thinking about. And I would say there's an ethical imperative to think about these things. You'll note, though, that the studies that have been done don't focus on persons with a dementia. And my understanding as to why that is presumably the case is simply because when a research protocol is proposed and when it goes through the research ethics board, interviewing individuals at various stages of a dementia who may be incapable of consenting to the research to speak about something as intimate and potentially sensitive as sexual expression, that is sometimes seen as problematic from a research ethics standpoint. I'm not saying it necessarily is, but that is presumably why there are less to almost no studies involving that actual population that we're interested in. All right, so when we think about the potential barriers to fulfilling sexual desires, there are a number, and some of these barriers are practical and they can be more easily helped, whereas others may actually stem from our individual perceptions, beliefs, our perspectives around what types of people should be having sex, what types of sexual expression are or are not permissible. And so some of these barriers are in place potentially because of the values that we may or may not hold, though some of the barriers are actually the values themselves. So this will become clear in a moment. So here are some of the potential barriers to actually responding effectively to a person's desire for sexual expression, which would maybe result in less of these ethical dilemmas arising, though not necessarily. So lack of privacy, lack of a willing and able partner, physical limitations, the attitudes, the perceptions of staff or family members, adverse effects of medications, feelings of being unattractive, and then, of course, just ageism or perceptions of sex and disability, which we've discussed exist in our society, and sexual consent or concerns about autonomous decision-making is another really big one. And I certainly want to acknowledge a wonderful mentor and colleague of mine, Dr. Lori Schindel-Martin, who is an incredible educator in relation to this topic and who I've had the pleasure with presenting on, and who developed some of these potential barriers based on her incredible research related to this. In addition to a former director of mine, Ann Hasters, who's also done work in the area. But we know that there are potential barriers that exist. And I'll just put a kind of fun, I suppose, but I think actually relevant quote in there, which is from Alexander Comfort's book, The Joy of Sex, a scientist and a physician, who says that people quit having sex for the same reason they quit riding a bicycle: general infirmity, thinking it looks ridiculous, or no bicycle, just speaking to some of the lack of, or the physical limitations that may actually exist, or the lack of a willing and able partner. But of course, what I'm most interested in from an ethics standpoint is all of these barriers, but I'm most interested in actually some of the perceptions of staff, of family members, of the way that ageism may reflect upon and relate to some of the ethical dilemmas that arise and some of the cases that we encounter and the ways that we respond to them. And so on the next slide, I'm going to talk a little bit about, and then we'll get to some of the kind of solutions responding to ethical dilemmas, responding to this idea that should people actually be permitted to, or in what circumstances should they be permitted to express themselves sexually. I think that part of the reason that some of these situations and some of these concepts are distressing and really complicated is actually because of a philosophical problem of personhood. This problem of personhood is this idea that a person who has a dementia is inherently different than their former self, and their former pre-dementia self is actually reflective of desires, of beliefs, of values that we need to uphold. So we may ask ourselves things like, are my clients or my residents or patients the same people as their pre-dementia selves? And if there's reason to believe that actually they are not, then for some reason, we decide that it is important to honor the prior autonomous wishes that were expressed. A question that sometimes comes up is just how much should prior autonomous desires or preferences actually be taken into account when determining how to proceed? If a person is expressing themselves in ways that they didn't previously, prior to their dementia or just prior to their older age, how much should we actually allow for that to be realized? Should we consider that to be an autonomous decision or not? And that's really hard and uncomfortable. And a really big question that I think is relevant to the work that we do is how much does our present happiness or the present interests of our clients matter for people with dementia? Does their present happiness or their current interests in expressing themselves sexually, should that actually outweigh their prior preferences? Because I certainly know that for myself, I've been involved in a number of cases where a person is expressing themselves in a very sexual way, and their spouse, their children will say they never would have expressed themselves in these ways in the past. So does that mean that we don't allow that to continue, even if they seem happy, even if they seem as though they're gaining some joy out of that current expression? These are questions that I think are up for debate. We can always chat about during the Q&A, certainly. Okay. So ultimately, we know what ethical dilemmas are, why people who express themselves in sexual ways and are older adults and have a dementia, why ethical dilemmas might come up. We know that the current context means that these ethical dilemmas aren't going anywhere. We have an increasing aging population. More people are going to be, rightly or wrongly, ending up in care environments. We know that wait lists are long. So we're going to be encountering these ethical dilemmas in our work. So how do we actually respond? And we know that ethical dilemmas comes from values and beliefs. And so one response to these dilemmas that I encourage people to do now or in the moment, and I'll often pose these to staff, is to engage in a reflective practice of your own values and beliefs. So asking yourself, and I would encourage you actually to even do this now in regard to your intuitive or immediate response to the cases that were put forward. So there were those 3 cases. We all reflected upon our immediate kind of gut reaction to them, right? Whether it was to separate the cans, to talk to the husband, whether it was to turn a blind eye, whatever that response was, is it in any way based on some of these questions? So thinking about what were you actually told, if anything, about sex, about sexual expression growing up? What does sexual expression actually mean to me now? What does that look like? How do I express myself sexually? And is that reflective of or relevant to the case that's currently in front of me? Is the person who's expressing themselves sexually in front of me, are they expressing themselves in ways that I just can't fathom doing? What values influence my own feelings about sex and intimacy in general? People value things for so many different reasons, and our own values, beliefs, preferences, perspectives may be based on just personal experiences. Some of the above 2 questions we just explored, they may be based on cultural, religious perspectives. Are there certain types of sexual practices that I find to be morally or ethically permissible? Are there certain types of people that I think should or should not engage in sex? I think this is important, that if I were the client, if I were the resident or patient, and we're all quite bad at placing ourselves in a future position and putting ourselves in other people's shoes, but doing the best that we can, how do we think we would want someone to respond? And how might my own sexual values, views, or preferences, experiences actually influence my perception of others? So engaging in these reflective practices can sometimes help us respond to ethical dilemmas in our workplace differently, or at least pause. And I like to think of ethics as a pause button. And I think these questions help us do that. Another way of responding to some of the ethical dilemmas that arise, I think particularly when it comes to sexual expression and older adults, these really complex value-laden cases, is to use an ethics framework. I know at Baycrest and a lot of other organizations, there's a framework that's called the IDEA framework. We're meant to identify all the facts of the circumstance, determine what principles are relevant, explore all the possible options. How can we respond to this? What's legally permissible? And then we act. What I encourage when it comes to these particularly value-laden topics is a bit of a longer process to, identify all the facts of the circumstance. Are there any clinically relevant indications, information? Are there any, how old are the individuals? Do we know anything about their past preferences? What medications are they on? There are a lot of facts that we can presumably pull out of any case that we see in front of us or are consulted on. So do that. Figure out what are the relevant ethical principles. Is it this autonomy and non-maleficence conflict? Is privacy relevant? Is trust with the family relevant? And then I encourage us to examine our own values and beliefs and preferences. Typically, this happens as a team. Are there differences? If there's differences, then that's why there's an ethical tension. explore the options, and oftentimes external consultation can help as well. So connecting with your ethicist, with another expert in the field, someone like Dr. Laurie Schindler-Martin. There's lots of people who are available for external consultation when these circumstances arise, when people don't know what they should do, because when you are so ingrained in it and when it is so valued, it's really hard. And then acting and reevaluating. The other and the last thing that I will say, and then I want to hear your thoughts and questions, is just that I would encourage everyone when it comes to these types of ethical dilemmas to put forward a balanced and a proportional response. What I mean by this is that oftentimes in ethics, what we'll say is that when there's an ethical dilemma in front of us, like the ones that we just explored, the way of determining if a response is proportional is by exploring the likelihood of harms and the significance of potential harms that may result from any action or inaction. So when two individuals with dementia are holding hands, the proportional response to that is going to look very different than two individuals with a dementia engaging in penetrative intercourse. We want to step back whenever there's a case in front of us and think, how likely is it that a harm might arise? And if a harm does occur, how significant would that harm be? And so if we do think about penetrative intercourse versus that of handholding, and we think about the possible harms and the likelihood of harms, I think it will soon become apparent that the proportional response is going to be very, very different for those two circumstances. And I'm a big advocate of proportionality and proportional responses when ethical dilemmas arise, because sometimes we do turn to, for good reason and with great intentions, sometimes we do turn to the most restrictive type of approach or response, again, for really good reason, but we could have actually done something very different that would have been proportional and perhaps more person-centered. So just as a recap, of course, I think we're all here. I don't really need to go through this, but I think that one of the most important things just to kind of drive home is that sexual expression is people are going to express themselves sexually that are older adults living in care environments. There's an ethical imperative, I think, to explore these types of cases, explore this topic, and have approaches to respond, developing guidelines, developing policies, taking a step back and engaging in self-reflection, using ethics frameworks so that we aren't so taken aback and so that we can respond proportionally when these circumstances inevitably occur in our environments. And so this is being recorded, of course, so you'll have access to, you can see some of the references, but please do feel free to reach out. This is a topic that I'm quite passionate about, and this is one very specific kind of short presentation. Anything related to this topic or otherwise, I'm very open to chatting about. Please don't hesitate to send me an email anytime. And perhaps with that, I'll stop sharing my screen. I would love your thoughts, questions, perspectives, feedback, outbursts, really anything. Thank you for listening and for being here.
Thank you so much.